Hi, everyone. Tonight we have another CB specialty VMR, and this time hepatology will be the focus. And for that, we have three incredible guests. We have Walker, we have Hersh, and we also have Rachel. So first, Dr. Shroff, he's a transplant hepatologist at the UNC and a liver fellow co-founder. Thank you for coming, Hersh.
Thank you for having me.
I would love if you could talk a little bit about yourself, what you do outside of medicine, why you chose hepatology, and also talk a little bit about your project, the Liver Fellow.
Great. So as was mentioned, I'm currently at the University of North Carolina in Chapel Hill, where I'm a transplant hepatologist. I could just talk a little bit about where I did my training and everything that brought me to this point. So I started, I guess, way back at med school at NYU in New York University. During that time, also received a master's in health administration. Then I did my internal medicine residency at Mount Sinai, also in Manhattan. And then I moved to Chicago to do my fellowships in gastroenterology as well as in transplant hepatology. And then after finishing that, I came here to be faculty at University of North Carolina. In terms of why I chose hepatology, when I first applied to gastroenterology fellowship out of my internal medicine residency, I thought I wanted to just do GI and maybe specialize in inflammatory bowel disease, which is ulcerative colitis and Crohn's disease, in particular because I really enjoyed the chronic disease management, taking care of patients over a long period of time for a disease that's at the moment not really curable. And that was the main chronic disease within gastroenterology. And then very early in my fellowship, actually, I was exposed to the area of liver transplant, which to me was sort of mind-blowing and really changed my whole perspective. As you all know, cirrhosis, chronic liver disease, also a chronic disease that we manage over a long period of time, but these patients are some of the sickest in the hospital, and being able to take them from, for some, their deathbed to transplant and then see them walk out of the hospital and then months or even years later, they're back to sort of normal almost, is really just something that opened my eyes to a whole area where we can help people that seem difficult to help. And so that was sort of the moment that I decided I wanted to do hepatology, and specifically transplant hepatology. What I do for fun, now that we moved from big cities down to North Carolina, we have a big house with space. And so been doing a lot of backyard projects. Wife and I are getting into some gardening. I like to read when I have time, non-medical things. I most recently read Thinking Fast and Slow by Daniel Kahneman, which, if you all haven't read, is highly recommended. I think everybody should read it at least once. So that's a little bit about me. And then thanks for mentioning Liver Fellow Network. I'll just spend a minute or two speaking on that, and then we can get started here. Liver Fellow Network was a website that I started with a few other fellows when I was in my fellowship a couple of years ago. And if y'all haven't checked it out, you should definitely do that after this. It's www.liverfellow.org. The purpose was to create an online resource for free open access medical education directed at people interested in hepatology. So specifically, the initial intent was people in their fellowship. However, we've sort of expanded our audience to residents, medical students, and we've learned after launching that basically everybody uses this, and faculty, people sort of all across the spectrum. And the idea is just to share educational resources that we've all created during our fellowship and kind of make it open access. And so love to hear y'all's feedback if you ever use it, but that's a little bit about Liver Fellow Network.
Oh, thank you so much, Hersh. It was really, really good. And now we also have Dr. Red. Walker is a gastroenterologist fellow at UNC and a Rumbalist team member. Maybe you could talk a little bit about yourself as well, Walker?
Sure. Thank you so much for having me, Rafa, on the CB Solvers team. It's a privilege to be back on VMR. So good to see all of you. So I just want to sort of endorse the website I just shared in the chat that Hersh and some of his friends and colleagues have made. It's just like got amazing. I think anyone who likes CP Solvers content will love kind of the summaries of the differential diagnosis, the pathophysiology. They have like amazing infographics, podcast episodes, definitely worth checking out. So I'll start with what I do for fun. I love to see live music. It's been on pause, obviously, during the pandemic for a few years. And usually I definitely make it to a lot of smaller and bigger concerts. And I've been getting back to that here, especially living down in North Carolina now, where it's warm most of the year and can easily do that outdoors, which has been great. And I chose, I think, even though I don't think I'm going to go into liver disease, I'm either probably going to be a general gastroenterologist or maybe focus on the esophagus. I actually, the first patient I took care of on my GI clerkship as a medical student had acute liver failure of unclear etiology. And similar to what Hersh was saying, it was what attracted me to it was the mix of really kind of like people who are really sick and have a lot of complicated pathophysiology, and also kind of chronic illness, whether it be on the IBD side, esophagus side, liver side, where you can follow them and actually do procedures for your patients as well. It's that nice mix of kind of the cognitive side and reasoning skills along with some of the procedural side. And so I've loved my training so far. I'm finishing up my first year now. And as Rafa mentioned quickly, for my side, when I was an intern, I found there was sort of like not a ton of resources on just practical management, kind of quick hitting podcasts. This was right when CP Solvers, of course, was getting much bigger. And so a couple of friends and I started the Run the List podcast, and similarly we have infographic type handouts we do as well for a range of internal medicine topics. And our first was liver and GI disease. And we are about to re-record that this summer because it is very old and done 4 years ago at this point. So keep an eye out for that this summer. And again, thanks for having me.
Oh, it's such a pleasure. I'm such a fan of the podcast. It's really, really incredible.
Appreciate it.
We also have Rachel. Rachel, could you introduce yourself as well, please?
Yeah, absolutely. I'm Rachel. I'm a fourth-year med student at UNC School of Medicine. I just want to reiterate what Walker said. I'm like super excited to be here. I love these VMRs. It's like a dream come true to be on one. So thanks so much. I'll start with what I do for fun too. I have a dog. I hang out with my dog a lot, take her on walks and runs. I've also been really into games recently. Doing a lot of like foosball, a lot of chess. And then why I want to go into internal medicine probably has to do a little bit of like why I like games too, like puzzles, which is, I'm excited about this case because I think it is a bit of a puzzle. And then since this is a specialty episode, I'm doing a research here right now in hepatology. And I guess where my interest comes from hepatology is similar to what Dr. Shroff Hersh said, how multiple people have told me in the past about how liver disease patients are definitely the sickest in the hospital. And I didn't realize that like to its extent until I was on third year. My research now and what I really am interested in, if I go into hepatology, I think is a really interesting area, is trying to prevent those from happening. So I'm working on a few research projects with like amazing doctors who are also researchers who are trying to improve the diagnostics and screening for a lot of these chronic liver diseases. So I think that's a cool area of this specialty. Thank you all so much for having me again.
Yeah, definitely. Thank you all for coming. And to help with the session, we have Madalena. Madalena, could you please introduce yourself?
Yes, hello everyone. My name is Madalena, also go by Maddie. Really, really excited to be here, and I loved hearing all of your guys' stories about what led you to hepatology and just some of your interests. Something that I like to do outside of medicine is, it's been really, really beautiful in New York these days. So I've been trying to go to as many parks as possible and either just walk around or go for runs, listen to music. So that's what I've been doing recently. Excited to be here.
Amazing. Thank you, Mari. And we also have Vale. Vale, could you please introduce yourself?
Yes. Hi, everyone. I'm Vale. I'm from Peru. I'm a sixth-year medical student, and I love to hear all your passion for hepatology and your stories and your hobbies. When it comes to what I love doing outside of medicine, I love running. I love trail running specifically. So I'm right now in Miami, and it's been a little hard to find trails over here, but I'm still looking. So I'm ready to start the case.
Yeah, thank you, Vale. So maybe Vale will be describing. Okay, so whenever you're ready, Rachel.
Yeah, absolutely. So this is a 44-year-old male who initially presented to an outside hospital ED 6 months ago with abdominal pain. He was found to have choledocholithiasis and cholangitis, and his status post-cholecystectomy and ERCP with biliary stenting. He subsequently redeveloped cholangitis after stent removal, requiring additional ERCP and stents. And in the process of all of this, he was noted to have extensive esophageal varices on cross-sectional imaging and was referred to the hepatology clinic for further evaluation. And of note, he currently has no abdominal pain. And that's the end of the first aliquot.
Amazing. Thank you, Rachel. So Walker, how would you dissect such a piece of information?
Sure. So just to kind of summarize what this patient's coming in with, as we hear it, sort of my problem representation, right, is this is a guy with now kind of a subacute history of recurrent choledocholithiasis, who has required at least one ERCP. I guess we heard about, or had a stent placed, so has had multiple manipulations within his biliary tree, and we will get a little more information on that probably, but just to sort of interpret to choledocholithiasis, right, just being stone in the actual bile duct itself, which can be symptomatic, which is probably what he was coming in with. It's not like we have that'd be symptomatic choledocholithiasis. Unclear exactly whether he truly had cholangitis and was infected at that time, but has now had ERCP, which is going to place him at risk of kind of other structural or infectious complications, having had his biliary tree manipulated. And then he's coming into clinic to see us with esophageal varices, which that is making me already start to think about, first of all, it's why he may have esophageal varices, which is likely related to portal hypertension. And so then you can start to sort of think about the differential for portal hypertension, right? And so all the key, the common things being common, you're going to immediately start to think about in any person coming in with portal hypertension or varices, you're thinking about things like alcohol and the other differential for chronic liver disease. But what's interesting is we already know about this gentleman has had some issue with his bile ducts. So that makes me think kind of at the top of the list, is this someone who's had something like PSC or some other structural, like congenital issue with his bile ducts that's kind of led to portal hypertension, which could result from a few different things, either pre or intra or post hepatic. And so I'm really like, at this stage, I'm going to make sure I take a really detailed just clinical history myself and put together the story and what risk factors there may be for infectious etiologies. You want to think about malignancy always, even though he's a younger guy, and social history, of course, and probably just dig into a little bit more of like if he had anything before this, or if this is just 6 months he's presenting with. Already an interesting case.
Yeah, incredible breakdown, Walker. Could you talk a little bit about Dr. Hersh? Do you have anything else to add that comes to mind?
Yeah, Walker did a great job so far, but I think although we feel like we're blind at this point, we don't have much medical history, we don't have his labs, we don't have prior imaging. In fact, just these couple sentences, I think, actually give us a lot of very interesting information, and definitely Walker alluded to a lot of this, but I think the first question always has to be, why did he form stones? And why did he form them multiple times? And a little bit of that requires us understanding why one forms stones and what types of stones one forms in the first place, right? Choledocholithiasis, as Walker mentioned, is a stone in the common bile duct. Now, the biliary anatomy involves more than just the common bile duct, but you have a very wide biliary tree that disseminates through the liver, and then you have sort of this offshoot of your cystic duct, which leads to the gallbladder. So stones can form in the gallbladder and then travel into the common bile duct, or they can form directly in the common bile duct or in the bile ducts in the liver. And he's a male. We think women tend to have a little bit more risk of developing gallstones. Some risk factors that we think about are age, right? So, he's at that sort of age, but perhaps you want to think about obesity being another risk factor. For women, pregnancy is a risk factor. There's also, pigmented stones that can form, black and brown pigmented stones. These are slightly different risk factors, but if there was a history of hemolysis or some sort of underlying disease that predisposes him to chronic hemolysis, he might be more likely to form a brown bilirubin pigmented stone. Of course, where he's from also may make a difference. Eastern Asia tends to have parasitic types of infections that can kind of predispose people to developing stones. So these are some of the questions that I have. And again, Walker mentioned getting a detailed history to figure out some of these things. We can talk a little bit later about why he had an ERCP versus his gallbladder removed. I think that's important to kind of think through. And then, of course, the esophageal varices is what mainly piques my interest as a hepatologist here. I don't care as much about the ERCPs and those kinds of things, but when I see esophageal varices, that definitely makes me wonder how long has this been going on for, and kind of definitely changes some of the differential here for what could be causing his stones.
Just incredible, thank you. Rachel, could you please continue?
Yeah, that was great. Okay, so for the second aliquot, I'm going to jump right into the ROS. So he reports a remote history of chronic intermittent diarrhea and abdominal pain, as well as occasional rectal bleeding. And these GI symptoms were worked up with a colonoscopy about 7 years ago. And the patient was told that he has hemorrhoids. He also has a remote history of intermittent fevers, which have also subsided. For the pertinent negatives, he denies weight loss, nausea, vomiting, hematemesis, confusion, yellowing of the skin or eyes, itching, increased abdominal girth, leg swelling, shortness of breath, and rashes. His past medical history is notable for chronic thrombocytopenia and fluctuating pancytopenia, which was worked up by hematology about 5 years ago with a bone marrow biopsy, which was found to be inconclusive. And then his other past medical history is the hemorrhoids that I had mentioned. For surgical history, he just had the cholecystectomy 6 months ago and no other surgeries. Family history is unremarkable. Everyone's pretty healthy. His social history, so he lives with his partner who's healthy. He works as a writer and has always been an avid traveler since he was a young man. He drinks about 2 glasses of wine each week and denies any history of IV drug use. He doesn't take any medications or supplements, has no known allergies, and I'll get to his physical exam. Yeah, I can get to it now. So his physical exam, I'll start with his vitals. So his blood pressure is 109/77. His pulse is 71. Temperature is 37.5. He's sitting at 100%. BMI is 27. In general, he's well appearing and no acute distress. He, for his HEENT exam, he shows no scleral icterus or sublingual jaundice. On GI exam, his abdomen is soft, non-tender, non-distended. He has normal bowel sounds, no ascites, no overt masses or hepatomegaly, but does have some fullness in the left upper quadrant. For the cardiac exam, he has regular rate and rhythm, no murmurs, rubs, or gallops. And pulmonary exam is normal, clear to auscultation bilaterally. On his derm exam, he has no jaundice, spider nevi, pulmonary erythema, or jaundice. His neuro exam, he's alert and oriented, no asterixis. And he also has no appreciable lymphadenopathy or gynecomastia. And that was a lot for this aliquot, so I'm happy to repeat anything if needed.
Incredible. Valley, do you need any information? No, everything. Okay, so maybe we can start with Hersh now. What are you thinking?
Okay, yeah, there's a lot of good stuff here. Let's see where we should start. Let's just go in order here. So the review of systems is really helpful here. And I think I briefly saw a couple folks mention in the chat some things that I was also thinking about when I heard. So chronic diarrhea and abdominal pain. And so certainly there's a wide differential there, but if you add that into what we already know that he has some biliary issues, you do wonder if this is someone who has inflammatory bowel disease, in particular ulcerative colitis, but also Crohn's disease. Those individuals have a moderate risk of developing primary sclerosing cholangitis, PSC, which is essentially an autoimmune disease of the bile ducts that causes stricturing and can predispose individuals to gallstones as well as other pathology. I know that he was worked up and was told he has hemorrhoids, but I'd want to know a little bit more about the extent of that workup. On the other hand, chronic infectious etiologies of diarrhea may be able to tie together this if there's some odd atypical infections that can also affect the biliary tree. So these are some things that we're going to want to know a little bit more about. Did he get an infectious workup of his diarrhea? And other viral types of studies. HIV is a viral test that I'd probably want to check in this gentleman just off the top of my head. Let's see, past medical history. So chronic thrombocytopenia, I think it's really worth taking a moment to talk about this, both in the setting of this case, but just in general. I'm probably a bit biased, but I tend to think that anyone with thrombocytopenia, in particular, if they have any identifiable risk factor for a chronic liver disease, one of the first things we should all be thinking about is if the thrombocytopenia is reflective actually of advanced liver disease and portal hypertension, perhaps on equal level with thinking about hematologic issues, if not maybe even first. All too often, I'll see patients who have seen hematology, have had bone marrow biopsies, and have spent years with everyone scratching their heads as to why their platelet count is low, and then they get sent to me and we tell them that they have had cirrhosis for many years. And this is not an exaggeration. I probably see one of those a week at least. I'm sure there are many other individuals who actually do have a hematologic issue that I don't see, but anyway, at least think about liver disease and your differential there. And part of the reason for that is due to, I think was just mentioned in the chat, thrombopoietin deficiency, which is from the liver, but equally big part of the reason for that thrombocytopenia and liver disease is due to portal hypertension and splenic sequestration. In addition, there could be nutritional and other sort of components that contribute to the cytopenias here. And pancytopenia is also, can be associated. There's reasons to have anemia and leukopenia in patients with cirrhosis too. So that's all can be consistent with chronic liver disease here. No other surgeries besides the cholecystectomy that we already knew about, and no medications. The family history is important here too. There's definitely a genetic component to some liver diseases, and while some are not completely hereditary, there can definitely be a clue as to whether that's something that we need to be looking into. In terms of his health-related behaviors, I am interested to know about the wine use, which for a male in the United States, he is sort of at his recommended limit, which is about 2 a week or 14, two each week. Okay, I read that as 2 a day. Okay, so he's much below, but you always want to be thinking about that. That doesn't seem to be an issue here. And then going into his physical exam, I'll try to speed up a bit here. You want to look for manifestations of chronic liver disease. So Rachel nicely mentioned he did not have the spider angiomata, gynecomastia. I will say that while these, if present, definitely give you a big clue, the absence of them, in my opinion, doesn't necessarily tell me too much. I've seen many people with cirrhosis who don't have these findings, but it's still nonetheless something good to look for. Those are some of the main things that off the top of my head. Walker, I don't know if you have anything to add there.
Sure, thanks, Hersh. That was great. And thanks, Rachel. It's a really interesting case. Yeah, just kind of maybe moving backwards a little bit from where we just were. The physical exam, I think that's a huge point, right? Like when we're in med school, I was always thinking we would always see patients with kind of these more end-stage sequelae sometimes, and it's not the case. But certainly you could imagine there may be some splenomegaly that was palpated on exam. You can certainly see that. And I think like the physical exam otherwise is sort of reassuring against some other processes that may be going on. Like overall, this looks like a guy who's had something brewing in the background that we'll get to in a second, like some chronic process here, but he looks well overall right now. He's not like clearly malnourished. He's not someone who's clearly been sort of decompensated from a substance use disorder standpoint. And so that's kind of, again, sort of making us think what's been going on here that is not necessarily like clear on our physical exam in the acute sense. And, the fever, I don't know what that temperature ends up being exactly in Fahrenheit, but, he's had kind of these intermittent fevers. And so that may be something to kind of take note of as well. And completely agree, while we don't have the labs back yet, this is so important. The thrombocytopenia is like, if there's one sort of learning point, I think I talk a lot about when we have students and residents on service that I've just come to appreciate as a fellow, is those multiple mechanisms by which that is the case. And that's how I've come to remember it, right? It's both sequestration and a production problem. And that really also, like, while that is that's often the first lab that we may see that's going to clue us into this within liver disease. And so it's an early clue, but that in the question of pancytopenia and this history of varices, right, is sort of the way we're starting to think about this. Those are all non-specific signs that he may well have either chronic liver disease or portal hypertension for some other reason. And that then, probably even pre-existing 6 months ago. And now he has had another background we know about, and completely agree that like PSC here is something that is already rising to the top of my list. And just a couple of quick pearls that I've sort of learned about that disease, putting together a presentation earlier this year that I did not know as a resident at all. I've just become more familiar with it this year and working with the hepatologist, that it can be really non-specific, right? And the UC, more frequent than Crohn's, can be a relatively mild IBD. It may even be its own distinct process or like subtype of IBD. So it can be more subtle than people who come in with like severe acute colitis. And so that's super important. That's totally possible as an etiology. And I agree that other things you think about, is there some other inflammatory process? Is there some sort of malignancy or infection that may be kind of explaining both? But then again, getting back to the more specific thing we have is unusual, regardless of why he's making stones, that he's kind of presented with this choledocholithiasis requiring not only cholecystectomy, but ERCP2 kind of in this setting. Those two things together, while both non-specific, make us start to think like, how is his likely portal hypertension and his biliary tree overlapping here, and like what's kind of on our differential for that?
If you were consulted if you were in a consult, which labs and imaging would you be most interested in for this patient?
Yeah, I can give you my initial impression and then let Hersh sort of round it out. I think if we were, first time seeing this guy as a consulting clinic, right? This is where so much of our medicine does happen for patients like this in the outpatient setting. And we're seeing him in consultation. I think we always on the liver side get the MELD labs, right? By that means CBC, complete metabolic panel, and an INR. We always make sure we get that no matter what. Every time we're seeing a patient, I think we get those. And then we sort of also will think about, next thing in line will be, is there a serologic workup we would want to send for his disease? And in this patient, I do think that he doesn't have, it's not like this is clearly alcohol related or non-alcohol related steatohepatitis. Like we'd probably err on the side in this guy's case of thinking about things like iron studies, for thinking about hemochromatosis. We would think about disease, autoimmune hepatitis. We would think about, we would certainly think about PBC and PSC. So we sort of like err on the side of sending some of the serologies, I would think, in this guy that's relatively undifferentiated. And then I would also think about imaging wise, this is someone where we're going to want to know what the last MRCP showed, right? And of course, even just ultrasound of his liver imaging would be really helpful in his case too. And Hersh, spoke to sort of the idea of HIV and atypical infections as well.
Yeah, one other thing I would just add here is, we're talking a lot about him having portal hypertension, which he probably does if he has low platelets and varices and splenomegaly. But we need to remember that portal hypertension is most commonly caused by cirrhosis, which is the long-term process of scar tissue being deposited in the liver, which deposit along the sinusoids, which are the liver capillaries, and therefore sort of cause resistance to portal flow. In which case, yes, you want to ask yourself, if he has cirrhosis, why does he have it? And that's where Walker alluded to checking for a lot of the chronic liver diseases. But I would also mention here that we don't know yet that he has cirrhosis. We know he has a biliary issue, which can lead to cirrhosis, but this is a little bit more maybe advanced, for medical school. But it's important to know that biliary disease in and of itself can lead to portal hypertension in the absence of scar tissue or cirrhosis. And we think of that as sort of prehepatic portal hypertension, depending on the biliary disease, because of the location of the smaller order bile ducts in the liver in proximity to the smaller order portal vein branches, that inflammation or around the bile ducts can compress the portal vein branches and lead to portal hypertension before the sinusoids without requiring that fibrosis deposition. So I guess to summarize that, he may just have biliary disease that's led to portal hypertension, and he doesn't have cirrhosis at this point. So I might, I probably want the basic labs that we're going to get here to kind of get a sense of what his liver panel looks like. But in clinic, I would probably order a fibroscan on this patient up front. Now, a fibroscan is a nice non-invasive way of assessing liver stiffness. And if that's very high, might clue me in more to this person having scar tissue or cirrhosis, and may sort of change the rest of the labs I order at the end of that visit. Whereas if that's relatively normal, I may start wondering, is this prehepatic, non-cirrhotic portal hypertension from some biliary process? And that's where his prior imaging, like if he's got an MRI or an ultrasound or something, might help me sort of see what's going on in his bile ducts.
Incredible, thank you. Rachel, could you provide some more information, please?
Yeah, so we'll start with the labs. I'm going to start with the hepatic function panel. So his AST was 32, ALT was 40, alk phos was 111, his total bili was 1.1, albumin was 4.3. He had an INR of 1.1. The relevant CBC findings were platelets of 76, white blood cell count of 2.7, hemoglobin of 13.3. He had an absolute eosinophil count of 0.1, which was 4.3%. He also had hepatitis serologies ordered, HIV, and a quantiferon gold test, which were all negative. He had a negative ANCA. For the imaging, so some imaging came from the outside hospital, so nothing was ordered at this time. So the MRCP showed one intrahepatic and one extrahepatic stricture, did not show multifocal stricturing and dilation. You can see the colonoscopy that he got 7 years ago was a true negative colonoscopy, with the exception of the hemorrhoids. He also got common bile duct brushings, which were negative for malignancy. And during one of the ERCPs, they did bile duct biopsies as well, which just showed mild, acute, and chronic inflammatory changes and no specific findings. Other imaging, he had an abdominal MRI which was also performed at the outside hospital. And it showed a few things. It showed normal liver morphology and volume. It revealed splenomegaly measured at 19 centimeters, extensive distal esophageal varices and portosystemic collateral shunts. He also had fibrosis throughout the porta hepatis interstitium and a portal vein thrombosis with cavernous formation.
Wow, this case is going on in turn, right? So Walker, what are you thinking? Does this change your differential somehow?
Yeah, I mean, I'm glad I demonstrated the way that I was thinking, like, it's Hersh, like, I'm thinking just like we get called all the time, right, for constant thinking, like, where's the like, what's the etiology of cirrhosis, and kind of going right to that, right? And so now I'm like backing back up for a second and thinking, okay, so again, this is really interesting. We have labs, again, just kind of going in order of how we got the information. The platelets we've talked about being low. The fact that the INR is 1.1 is really, from sort of a synthetic function standpoint, is really reassuring. I feel like when we see INRs that are like 1 or really close to 1, it makes us think that like the synthetic dysfunction, and it makes kind of that level of cirrhosis a little less likely. We have both sort of the hepatocellular and cholestatic side of the liver enzymes are relatively normal as well. A few of those key infectious studies that we highlighted are also normal. And so I am now starting to think about what structurally, I'm just kind of thinking out loud here, but what structurally, right? It's kind of focal findings. We've talked about PSC with the bile duct findings. That seems pretty local, though. It would be both, and it's both intra and extrahepatic. And what sort of accounts for that? What accounts for, I believe we said, we did have those. Again, I'm always thinking malignancy when I'm thinking like what's obstructive, what's causing clot. And the fact that, and Hersh can probably fill this in better than I can, my understanding is like the brushings, right, that you'll sometimes see from an ERCP is, you do it, we send it a lot. It's not super sensitive is my sort of understanding. And same may be true for something like a cholangiocarcinoma, right? You don't always catch the area that you're trying to sample there. And so we have a process now with this portal vein 2 that is again fitting with something more chronic if it has the cavernous form transformation. So something has caused kind of abnormal blood flow that's a little bit more focal. That could help explain a lot of the findings. This clot being more chronic could help explain sort of this non-cirrhotic picture we're getting, leading to some portal hypertension back from sort of pre-hepatic. I think I would understand it as pre-hepatic portal hypertension. And the question, right, is how do we kind of connect this stricture and the portal vein clot? So that's how I'm sort of thinking about it at this point. And Hersh, what would you sort of fill in, and where are we going from here? It's really interesting.
This is a fascinating case. Not an easy diagnosis. I'm still not even sure really what's going on here, if I'm being perfectly honest. So, and just so you know, my daughter is being put to sleep, and so you might hear some background noise. I apologize. But okay, let's see. Yeah, normal liver tests. Very reassuring. I mean, essentially normal. The alkaline phosphatase may be just borderline, but I would sort of consider that in the normal range. One thing to just kind of point out here, I'll oftentimes look at the AST and the ALT and the sort of ratio there. This isn't a perfect marker, but when you're wondering if someone has chronic liver disease or cirrhosis, that's a condition that oftentimes causes your AST number to be higher than your ALT. Even when both are relatively normal. And so that's known as the Deritis ratio, DERITIS. It was described many, many years ago and has fallen out of favor now because we have more advanced ways of telling whether someone has cirrhosis, but it actually is a pretty good marker. His is not that, so the AST is not higher than his ALT, which is, just one thing that I always note and kind of goes along with maybe he does not have chronic fibrosis or cirrhosis, just like we just said. let's see, negative ANCA. Sometimes people think of that when we're wondering about PSC, and certainly there is an association. I will say, clinically speaking, this is not something we frequently check when we're wondering about PSC in individuals. It's not really too sensitive, and also not very specific. And most of the time we'll be getting imaging that's going to be diagnostic, like the MRCP. And so it's not something that I typically use, even when I am wondering about PSC. Okay. Okay. So most importantly here, I think let's just focus on this MRI finding. So he has all the findings that you're seeing here are essentially related to portal hypertension, splenomegaly, varices, other shunts in the abdomen. And then he's got this portal vein thrombosis. So that's most likely, the etiology of his portal hypertension. Now, 90% or so of portal vein thrombosis actually does occur in people with cirrhosis. And so while I said it doesn't look like he has that based on the information we have so far, you still do, this is probably someone who has enough of the things that you'd want to make sure with, like I said, a FibroScan or something like that, as I mentioned. But if he doesn't have cirrhosis, why did he develop a portal vein thrombosis? And this finding of fibrosis around the porta hepatis interstitium is somewhat interesting. If you don't mind, Rachel, did you mention where he's from?
I did not. So he is originally from here in the US, but like I said, he's like an avid traveler. So he's lived kind of in all places. He's lived like on multiple continents for years at a time.
Okay. I am wondering about some atypical infections here. Worldwide, one of the most common causes of portal hypertension is schistosomiasis, actually, not something we see very commonly here. But schistosomiasis can cause fibrosis in the portal vein and eventually lead to portal hypertension. And so, he's got chronic diarrhea, he's got some pancytopenia. That's definitely something that I'm starting to think a little bit more about. Those other parasitic infections that I sort of mentioned that can cause biliary stones and things like that are still maybe something you want to consider, although they don't usually affect the portal vein in this way and don't necessarily lead to portal vein thrombosis. Those are things like, oh God, I'm digging deep now, but Conorchis and Opisthecornis, or the sort of nematode tapeworm types of infections. You all probably have heard about these much more recently than I have, to be perfectly honest. But definitely something I'll have to kind of read about if I'm looking at this patient and thinking about those things. And so we're probably going to want to do a little bit more of a workup of his diarrhea and some of these parasite, stool, ova, and parasites and things like that. What else? I just made some notes here. The eosinophil count being normal, though, does make you wonder if that's not really what's going on here. The last thing I'll mention is that in someone who develops a portal vein thrombosis, which I didn't go through the entire differential here for portal vein thrombosis, but this cavernous transformation is just, we'll spend a minute on. So if I could draw something out for you, I would, but to make it a little bit easier to understand. But if you've got a portal vein that's blocked off, the cavernous transformation refers to tiny little collateral vessels that kind of form around that clot to try to bypass that clot and still deliver blood to the other side of the clot in the portal vein. And so that's what this cavernoma is. And you can see it on imaging. And as Walker mentioned, that is a sign of a little bit more chronicity of this portal vein thrombosis. When you have that cavernoma, what it can do is actually the cavernoma itself can compress the bile duct next to it and can cause something called a portal biliopathy. Also, this is a very uncommon condition, but I've seen it a handful of times, and that can lead to bile duct. It can sort of extrinsically compress the bile duct, leading to cholestasis, predisposing someone to gallstones, and all of the other things you normally expect to see when someone has biliary disease. And so if you're thinking the chicken or the egg here, did he have a portal vein thrombosis that formed the cavernoma and is now causing bile duct issues, or vice versa? Did he have some biliary issues that have led to a little bit of scar tissue and that decrease in flow through the liver is leading to portal vein thrombosis, and then subsequently causing portal hypertension? And so those are some of the things I think we need to look into here.
sounds really complex. Someone on the chat asked, can we expect some structuring from the procedures for the choledical cholelithiasis, or should this be suspicious for innate biliary pathology?
Yeah, certainly after a cholecystectomy, there can be some surgical injuries to the bile ducts, and you can get some strictures. You mentioned there was an intrahepatic stricture, I think, as well. So that's not necessarily something we would see. You know, they're not really going on the intrahepatic side when they do the surgery. And so I wouldn't necessarily expect that. When you see kind of multiple locations, you are wondering about something more primary in the bile ducts. But that's a great thought and certainly can happen after a cholecystectomy.
Thank you. Rachel?
Okay, great. That was wonderful. The fourth aliquot is pretty short. So at this point, additional data from the outside hospital comes, and you see that he's had a liver biopsy. His liver biopsy shows significant periportal fibrosis, no cirrhosis, mild non-specific inflammatory changes, no steatosis or granulomas. And looking through his labs from the outside hospital, you see that he had eosinophilia that had been up to 9.9% about in the past years, but has been downtrending in the past 5 years.
Just to make sure, Rachel, this is the last aliquot before revealing the final diagnosis?
Yes, yeah.
Okay, thank you. Hersh, what are you thinking?
Walker, why don't you tell me what you think first? I have some thoughts here, but it's not this is not easy, everybody. So
yeah, this is so I mean the EOs, right, from like we said, like you always think, I mean, like EOs, I'm just going to think broadly about first because it was a prior finding that was significant at that time. And so there you always think, like we were alluding to, these atypical infections. People have been throwing out, you know, tick-borne or like schisto or something like that. We always think medicines for that. In our world, we do think about like eosinophilic gastrointestinal diseases, from like EOE to other diseases that can affect kind of any area of the GI tract, or any sort of reaction to something typically. Like I think of this, right, typically as a reaction to something, and I'm trying to think, yeah, if that's an infection or sort of a process involving the bone marrow, and having a hard time kind of knowing why it would then be downtrending as well, unless there was something that's kind of clearing, right? Like an infectious process with time, and now we're kind of seeing sequelae of it with the structural changes in the bile duct, and then that kind of, as Hersh explained, leading to the PVT. And then I'm still like really not great at reading and interpreting liver biopsies, to be honest. But yeah, I may let Hersh kind of chime in on how he would interpret the specific biopsy findings.
yeah, no, that's great. I also wonder why the eosinophil count is downtrending. Perhaps there's some treatment that he was given that we don't know about yet. But definitely, I would wonder about some parasitic infection here. I think that's got to be one of the highest on our list here. And so again, as I mentioned, a stool O&P. The biopsy, yeah. So periportal fibrosis, mild inflammatory changes, no granuloma. Okay. So the granulomas is important here. Now there are some biliary diseases. Granulomatous liver disease has a pretty wide differential, which includes various infections, but also in particular, some of the things we're wondering about here, like PSC and PBC, specifically PBC being primary biliary cholangitis. That's a bit of a different process and definitely not something that we're thinking about here. That wouldn't cause necessarily recurrent cholelithiasis and some of these other things that we're seeing. But that's a granulomatous liver disease that can affect the bile ducts. And so definitely something that we need to, would need to look for, and he does not have any granulomas. Otherwise, sarcoidosis is a disease that's systemic, but also affects the liver and can lead to granulomas. And then there's definitely infectious etiologies as well, but again, no granulomas. Periportal fibrosis with some mild inflammatory changes can definitely be seen in schistosomiasis. But again, is otherwise relatively non-specific finding. I mean, anything that's kind of chronically causing damage to the liver will start usually by causing fibrosis in the periportal area. And then that fibrosis starts to spread beyond the portal area, across the sinusoids to the kind of the veins, which kind of are the outflow of the liver. And then you sort of, that's where you get, it's what we call bridging fibrosis. And then eventually you get nodule formation, which is cirrhosis. And so that's sort of the progression of kind of chronic damage. And so overall, this is not too revealing as far as I can tell, but certainly does not, can go along with schistosomiasis and something to think about.
Oh, incredible. Thank you so much, Walker and Hersh. So what's the final news, Rachel? Everyone's on the edge of their seat.
Yeah, so he had an IgG sent for schistosomiasis, which was positive. He also had stool samples sent for ova and parasites on 3 separate days. And the first one was negative, but the one of the next ones was positive. And he was diagnosed with hepatosplenic schistosomiasis.
Oh, incredible case. Thank you so much, Rachel. If you could say something, Walker and Hersh, that us medical students and residents should take away from this case, what would you tell us?
This is why you should do hepatology. You can come to a clinic with Hersh and see this every day. No, I mean, this is a great case, because it's like, what I love about the way that this went is in the, I'll get to like kind of clinical takeaways in a second, but like from a reasoning standpoint, it was so amazing to see in the chat a little bit, like everyone kind of like working to get there together. And especially like when things from a reasoning standpoint, right? We see this patient have a lot of findings that we do see, but we see them in more expected situations, right? We see choledocholithiasis in people without portal hypertension all the time, and we address that. We see diarrhea all the time, and we are able to work it up. We see, we see varices. We certainly see eosinophilia for different reasons. What was beautiful about this case is like we saw all these different things, and it was really tricky to like bring them together with one explanation. And I think, not only Hersh sort of working through it with some expertise there, but like we all kind of like we're getting there together, I think, by thinking this is odd. This isn't something like we typically see. What is specific here? And like we honed in on the, I think the eosinophilia, we honed in on what could be kind of causing these more focal changes without actually causing cirrhosis. And we sort of put all the pathophysiology together in real time. And so my takeaway really is just stepping through the data together, right? And thinking about what is specific and what's non-specific, and bringing, working with the people on your team too, right? Like talking to colleagues, like we do this all of the time. When I was a student and resident, I didn't always realize that, but even like, I'm sure Hersh would say, all of his partners who are also transplant hepatologists, right? Like if a case isn't making sense, or like you're looking at a biopsy or trying to put things together, it's really great when you can just like work together and sort of step through this. And thank you, Rachel, for such a nice way to step through this case. Is like rare that you can have it all work so well and then have kind of the big reveal at the end. So excellent job. Thanks all for joining.
Yeah, and I'll just in the last couple minutes just add to that. I mean, I think very broadly speaking, it's really important as you sort of go along in your training and even beyond that, to realize that, I mean, this is a case that has, 100 of different pieces of information that can be very overwhelming and sort of hard to think through. But you start to kind of put things together and realize that most of them are secondary to some primary process, right? And so identifying that one thing or one or two things that really will hone you in on your primary process here is important, right? I mean, so for example, for me, I know he's got varices and thrombocytopenia and all that. I'm not too worried about that to begin with, because I know it's just secondary to kind of what's going on here in that very localized area of the bile ducts and the liver. And so I won't bog myself down necessarily with trying to figure out the entire differential for esophageal varices or thrombocytopenia, because I first have to figure out or even diarrhea, for example. I mean, these are all helpful pieces of information, of course, but there's a huge differential for diarrhea, most of which isn't really applicable here unless you take it into context of this primary issue, which is he's got bile duct issues, he's got stones. Think through what can cause that in a somewhat chronic fashion, and start asking questions that kind of hone that differential. Where is he from? What's his surgical history? Things like that, because you start thinking what causes bile duct issues. And pretty quickly, you'll start putting things together, and then everything else will fall into place. Why does he have the cytopenias? Why does he have the fullness in the left upper quadrant? Why does he have all these findings on his MRI? Sort of all that kind of falls very nicely into place, and you don't necessarily get so bogged down in that. Yeah, this was a fantastic case. Rachel, you did an awesome job. Thank you for presenting all of that. Don't know if there's any specific other questions that would be helpful for me to answer here.
Actually, could you comment on his prognosis? Are the changes reversible? Someone asks on the chat.
Okay, well, his schistosomiasis can be treated. Unfortunately, with the degree of chronicity in his portal vein thrombosis and the cavernous transformation and all the kind of collaterals that have formed, whether or not those are going to reverse are a little bit harder to say. That might sort of stay, and we'll be left with managing his portal hypertension going forward. Now, thankfully, if he has esophageal varices, there are things we can do by doing endoscopies and looking at them and banding them if necessary. And even if he does bleed from them, which hopefully he doesn't, but if he does, bleeding tends to be much better tolerated in people who don't have underlying cirrhosis or dysfunction of their liver, because they don't have this normal coagulopathy that goes with that and the difficulty tolerating bleeding events. And so, of course, we want to prevent him from bleeding, but his overall prognosis should be pretty good from a long-term perspective if he doesn't have cirrhosis, and if we can treat the schistosomiasis and just keep an eye on his varices.
Just incredible. Thank you so much.
If I can make one little clarification, it came up before about the eosinophils and how they were normal now. That also threw us off for sure. And that wasn't meant to trick you guys, but I was doing some reading on this, and I was reading about how with chronic infection, the worms and the eggs, the actual numbers of those can go down pretty significantly, but they can still have this kind of active infection, and so they might not have the classic eosinophilia and positive ova and parasite test that we're taught to kind of look for. And that's that. And then also the limitations of liver biopsy, how we didn't see a granulome on the biopsy, and how it was just amazing hearing you all talk through this case, because even when things were negative, the sensitivities of these tests you kind of had in the back of your mind that you're not hanging your hat on any one thing. So it was really, really awesome to hear your thought process, and thank you all so much. It was amazing hearing that.
Yeah, it was incredible. Thank you so much, Walker. Thank you so much, Hersh, for the fascinating discussion. Thank you so much, Rachel, for presenting the case. And before we finish the session, Marilena, could you please do the teaching points?
Yes, so I will jump into the teaching points. Rachel, that was such an awesome case presentation, and Walker and Hersh, really, I learned so much. I was running out of room for all the teaching points because there were so many gems in there. But just as a quick summary, just so right off from the beginning, we talked about how choledochothiasis indicates that there's a stone in the common bile duct. And we started off by asking some really important questions. Why are there stones in the first place? And why was this patient having recurrent stones? So we talked about the location that stones can form in the gallbladder, the common bile duct, and also ducts in the liver. And some risk factors are age, female sex more than male sex, obesity, pregnancy, etc. Jumping to portal hypertension, we can divide that differential into pre, intra, and post-hepatic causes. Cirrhosis is the most common cause, which is, as we know, scar tissue in the liver along the sinusoids. But importantly, biliary disease can cause portal hypertension in the absence of cirrhosis. When we learned that the patient also had chronic diarrhea and abdominal pain associated with this biliary issue, we talked about the association with inflammatory bowel disease, specifically ulcerative colitis, which carries a high risk for PSC. Then when we got some more history in labs, we learned that the patient had chronic thrombocytopenia. And it's important to ask this question, is the thrombocytopenia reflective of advanced liver disease through either TPO deficiency or splenic sequestration, or is it a primary hematologic issue? Jumping to the physical exam, this patient did not have spider angiomata, gynecomastia, etc. However, it's important that the absence of those signs does not exclude liver pathology. And then jumping to labs, we talked about the de Vritas ratio, basically, which is that an AST-ALT ratio greater than 1 is suggestive of chronic liver disease. And then lastly, jumping to the imaging findings, we talked about the cavernous transformation that was described on the MRI. And Hersh and Walker explained to us that what this means is that collateral vessels are forming around a clot, which generally indicates that this is a sign of chronicity. And an interesting pathology we learned is that a cavernoma can actually compress the bile duct, cause this portal biliopathy, stasis, and ultimately increase the risk for gallstones. And lastly, when we saw the high eosinophil count and the periportal fibrosis, we considered some parasitic causes of biliary disease like schistosomiasis, which is ultimately what this patient had. So thank you all so much. This was an amazing VMR and I learned so much.
Yeah, thank you so much, Mario, for incredible teaching points. Thank you, Vale, for scribing. Thank you, Walker. Thank you, Rachel. Thank you, Hersh. It was incredible. Thank you, everyone. Hope everyone have a good night.
Thank you, Rafa, for putting this together. Appreciate it. Have a good night.
Thank you, everyone. Have a good night.